Welcome to our session on neonatal physical examination. This is one of the most heavily tested areas on the neonatal nursing certification exam, and for good reason. It's absolutely foundational to our practice. We'll be focusing on the systematic approach to physical examination, how to properly assess gestational age, vital signs interpretation, and growth parameter assessment. I've highlighted the highest yield concepts throughout, so pay special attention to those as we go. Here's what we'll cover today. We'll start with a systematic approach to examination. This provides your framework for conducting a thorough assessment. Then we'll dive deep into gestational age assessment, which is hugely important both clinically and on the exam. We'll cover vital signs assessment and interpretation, growth parameters, and essential documentation practices. Throughout, I'll highlight the concepts most frequently tested on the certification exam. On the exam, you'll encounter a variety of questions about physical assessment techniques. They may appear as an infant presents with a sign, is this normal or not, which follow-up test is indicated, or what disorder do you suspect? The neonatal physical exam isn't just a routine task, it's a comprehensive evaluation tool that's essential in assessing how well a newborn is transitioning to extrauterine life. Despite all our technological advances, the physical exam remains one of our most powerful tools for identifying potential risks and disease processes. A good exam combines maternal and familial health histories, assessment of gestational age, and detailed physical findings to create a complete picture of the newborn's status. The exam will always be foundational to making accurate clinical judgments, and the test reflects this importance. Understanding how the exam asks questions about physical examination can help you prepare more effectively. You'll encounter several question patterns. First, direct knowledge recall questions ask for specific facts like normal vital sign ranges. Clinical scenario questions present a patient case and ask about assessment or management. Timeline questions focus on normal progression of development or reflexes. And interpretation questions ask you to analyze findings or measurements. These patterns appear consistently throughout the exam, so recognizing them helps you approach each question strategically. You'll also see professional judgment questions testing your clinical decision-making, like what's the appropriate response to acrocyanosis at 6 hours of life versus 48 hours? Maternal education questions test how you'd explain findings to parents. Anatomical questions focus on normal structure and function, like umbilical cord vessel numbers. And questions about reflexes and neurodevelopmental assessment are extremely common, asking you to identify specific reflexes or evaluate neurological status. The key is to read each question carefully and identify which type you're dealing with before answering. A systematic approach to examination is absolutely critical. Always start with general appearance and vital signs before you even touch the baby. This provides valuable initial information about the infant's overall status. Then proceed in a head-to-toe sequence to ensure you don't miss anything. Take time to observe before interacting. Watch breathing patterns, color, and spontaneous movements. Assess the infant's state, alertness, and movement, and always consider the perinatal history before beginning your physical examination. This methodical approach ensures thoroughness and accuracy. Timing matters significantly for an accurate assessment. The initial exam should be completed within the first hours of life to establish a baseline. Try to conduct the exam in a warm, stress-free environment to minimize physiologic stress responses that can affect your findings. The ideal time is when the newborn is in a quiet, alert state. They're more responsive, and you'll get better neurological assessments. Remember to modify your approach based on the infant's state and illness. The timing of your assessment directly affects the accuracy of your findings, especially for neurological and behavioral components. Before laying hands on the baby, gather essential history. This includes maternal and family health histories, genetic disorders, chronic conditions, and so on. Review antepartum complications and testing results. Be sure to note intrapartum events and delivery details. These heavily influence the neonate's status. Document any resuscitation measures needed and APGAR scores. And obviously, note any known anomalies or risk factors. This history provides critical context for interpreting your physical findings. These history elements are particularly high yield on the exam. Pay close attention to maternal medical conditions like diabetes or hypertension, which significantly affect the newborn. Note maternal medications and substance use, which can cause withdrawal or other effects. The timing and characteristics of membrane rupture relate to infection risk. Review all fetal testing results and abnormalities and document the presence of meconium or signs of distress. These details guide your physical exam and help you anticipate potential issues. The exam frequently tests the relationship between these history elements and physical findings. Your assessment begins with general appearance, before you even touch the infant. Note color: pink, pale, cyanotic, plethoric; posture, flexed, extended; and activity level: active, lethargic. Assess apparent gestational age based on overall appearance. Identify any immediately visible malformations or anomalies, and evaluate the overall state of comfort or distress. These initial observations often provide your first clues to potential issues. Understanding neonatal behavioral states is critical for a proper exam. In deep sleep, you'll see regular breathing and minimal movement. Light sleep shows some movement and possible REM. Drowsiness presents with variable activity and eyes that open and close. The quiet, alert state, the ideal state for examination, shows focused attention with minimal movement. Active alert presents with more movement and slightly less focus. And the crying state shows increased movement, shut eyes, and color changes. Recognizing these states helps you time your exam appropriately and interpret findings accurately. Vital signs assessment is extremely high yield on the exam. Normal axillary temperature ranges from 36.5 to 37.4 degrees Celsius, 97.7 to 99.3 degrees Fahrenheit. Heart rate typically ranges from 95 to 160 beats per minute at rest. Normal respiratory rate is 30 to 60 breaths per minute. For term infants, blood pressure ranges around 65 to 95 over 30 to 60 millimeters of mercury, and capillary refill of 3 seconds or less is considered normal. These ranges appear frequently on the exam, so commit them to memory. Remember that vital signs vary with gestational age and postnatal age, so context matters. Recognizing vital sign abnormalities is equally important. Hypothermia is defined as temperature below 36.5 degrees Celsius for term infants and below 36.3 degrees Celsius for preterm infants. Hyperthermia is above 37.5 degrees Celsius for term and above 36.9 degrees Celsius for preterm neonates. Bradycardia, heart rate at or below 80 BPM, is always abnormal in a term infant. Tachycardia is generally considered a heart rate at or above 160 to 180 BPM, and apnea is defined as a pause in breathing of 20 seconds or longer, especially when accompanied by color changes or heart rate changes. Expect questions asking you to identify abnormal vital signs and their clinical significance. Gestational age assessment is a massive topic on the exam. It's critical for determining morbidity risk and guiding care decisions. Remember that gestational age A assessment is most accurate within the first 48 hours of life, before physical characteristics start changing in response to extrauterine life. A good assessment combines both physical and neurological criteria. It helps validate or correct obstetrical dating and affects all normative comparisons. Without an accurate gestational age, it's impossible to properly interpret other assessment findings. This is one of the most heavily tested areas, so spend extra time mastering these concepts. Know these classifications. They appear frequently on the exam. Extremely low GA neonate, ELGAN, refers to infants between 24 to 28 weeks gestation. Preterm is any infant born before 37 completed weeks gestation. Late preterm covers 34 and 0 to 36, and 6 weeks gestation. These babies often look deceptively mature, but have significant physiologic immaturity. Term infants are born between 38 to 42 weeks gestation. And postterm refers to beyond 42 weeks gestation. Each category carries specific risks and considerations that you'll need to recognize for the exam. The exam frequently tests knowledge of gestational age assessment tools. The Dubowitz assessment includes 10 neurologic and 10 physical criteria. The Ballard New Ballard score uses 6 neurologic and 6 physical criteria, making it more practical in clinical settings. The New Ballard can assess GA between 20 to 44 weeks, with typical accuracy of plus or minus 2 weeks. For infants with estimated GA of 20 to 28 weeks, the optimal timing is within the first 12 hours of life. After that, physical changes and neurological responses start to adapt to extrauterine life, reducing accuracy. The test usually has a question or two presenting an infant or an element of their assessment on the tool, like the scarf sign or square window, and ask you what the gestational age may be. These physical criteria for GA assessment show up constantly on the exam. Skin transparency decreases with advancing GA, from transparent with visible vessels at 24 weeks to opaque with minimal vessels visible at term. Lanugo is present between 20 to 28 weeks and gradually decreases with advancing GA. Plantar creases first appear on the anterior sole around 28 to 30 weeks and progress toward the heel with increasing GA. Breast development increases with GA, with barely perceptible tissue at early gestation and several millimeters of tissue at term. Ear cartilage similarly increases with GA, and genitalia change significantly. In males, testes descend and scrotal rugae increase with GA. In females, the clitoris becomes less prominent and labia majora develop more fat deposits with increasing GA. The neurological criteria are equally important for gestational age assessment. Posture shows increasing hip adduction and flexion with advancing GA. The square window angle, wrist flexion, decreases with GA. Arm recoil, return to flexion after extension, increases with GA. The popliteal angle, knee extension, decreases with advancing GA. The scarf sign, ability to wrap arm across chest, decreases with GA, and the heel-to-ear maneuver becomes less possible with advancing GA. These neurological signs are more resistant to postnatal changes than physical characteristics, making them particularly valuable. Practice these assessments whenever possible, as they frequently appear in clinical scenario questions. Growth parameter assessment is another critical high-yield area. Accurate weight, length, and head circumference measurements provide essential baseline data. Always plot these measurements on appropriate growth curves. The CDC recommends WHO curves for infants 0 to 24 months of age. For very preterm infants, Babson curves extend from less than 22 weeks to 10 weeks post-term. Always compare measurements to gestational age norms, not just chronological age norms. Proper growth parameter assessment helps identify intrauterine growth restriction, macrosomia, and other growth abnormalities that significantly impact neonatal care. Growth classifications are frequently tested on the exam. Appropriate for gestational age, AGA, means measurements fall between the 10th and 90th percentile for that GA. Small for gestational age, SGA, means below the 10th percentile. Large for gestational age, LGA, means above the 90th percentile. Intrauterine growth restriction, IUGR, refers specifically to abnormal, diminished growth velocity, not just small size. The exam also tests weight-based classifications. Each classification carries specific risks and management considerations. Calculating neonatal growth rate is essential for monitoring infant nutrition and development. The basic formula is straightforward. Daily weight gain equals current weight minus previous weight divided by the number of days. This is simply the general rate of change formula, change in weight over change in time. Let's work through an example. If an infant weighs 3,000 grams at birth and 3,150 grams at 7 days of life, the daily weight gain calculation would be 3,150 minus 3,000, which equals 150 grams, divided by 7 days, giving us 21.4 grams per day. The same principle applies to weekly calculations. Just substitute weeks for days in the denominator. This calculation is clinically significant because we expect neonates to gain 15 to 30 grams per kilogram per day, depending on their gestational age and clinical status. Regular growth calculations help identify infants who may need nutritional adjustments or further evaluation. This case demonstrates essential neonatal weight calculation principles. The baby had a birth weight of 35,000 kilograms and weighed 3,100,000 kilograms at day 7. Let's calculate the weight loss. 35,000 minus 3,100 equals 0.400 kilograms, or 400 grams. To find the percentage weight loss, we divide 400 by 3,500 and multiply by 100, giving us 11.4%. This 11.4% weight loss exceeds the 10% threshold that typically warrants clinical evaluation. The baby requires assessment of feeding patterns, hydration status, and overall clinical condition. This case emphasizes the importance of systematic weight monitoring and recognizing when weight loss becomes clinically significant, requiring intervention rather than just observation. Understanding IUGR types is particularly important. Asymmetric IUGR, also called head sparing, shows disproportionate growth with relatively normal head size but reduced weight and possibly length. This typically results from late gestation placental insufficiency affecting cellular hypertrophy. Symmetric IUGR shows proportional decrease in all growth parameters, suggesting an earlier intrauterine insult affecting cellular hyperplasia. IUGR indicators include a wasted appearance, wizened facial features, diminished subcutaneous fat, and dry, flaky skin. These infants face increased risks of hypoglycemia, polycythemia, hypothermia, and other complications. Always note placental concerns in the history that might explain IUGR. Skin assessment reveals much about gestational age and overall health. Normal variations change dramatically with gestational age, from translucent skin with visible vessels in the very preterm to dry, peeling skin in post-term infants. Color assessment is key. Acrocyanosis, bluish discoloration of hands and feet, is normal up to 48 hours, but abnormal beyond that. You need to recognize common birthmarks and their significance. Café au lait spots, light brown macules that may indicate neurofibromatosis if numerous, Mongolian spots, bluish discoloration, especially on the back, and hemangiomas, vascular birthmarks. Common rashes include erythema toxicum, newborn rash with white papules on red bases, milia, tiny white cysts on nose and face, and miliaria, heat rash. Abnormal findings like epidermolysis bullosa, genetic blistering disorder, and staphylococcal scaled skin syndrome require immediate recognition. Head assessment starts with occipitofrontal circumference measurement, which must be plotted on an appropriate growth curve. The anterior fontanelle is diamond-shaped and can range from barely palpable to 5 centimeters across, while the posterior fontanelle is triangular and typically smaller than 1 centimeter. Sutures may be approximated, separated, up to 1 centimeter separation is normal, or overriding. Molding is a normal adaptive mechanism from the birth process that resolves spontaneously. You should also recognize birth trauma, like caput succedaneum, diffuse scalp edema that crosses suture lines, and cephalohematoma, subperiosteal bleeding confined by suture lines. Head assessment abnormalities are high-yield exam topics. Microcephaly, OFC below 10th percentile, may indicate poor brain growth or premature suture closure. Macrocephaly, OFC above 90th percentile, could be benign familial or secondary to hydrocephalus. A large anterior fontanelle exceeding 5 centimeters across may suggest hypothyroidism. A bulging fontanelle raises concern for increased intracranial pressure. And subgaleal hemorrhage represents a true clinical emergency. This bleeding between the scalp aponeurosis and pericranium can lead to massive blood loss and shock. The exam frequently tests your ability to distinguish between these conditions and determine appropriate management. For face, eyes, and ears assessment, start with facial symmetry and movement, checking for nerve palsies or abnormal development. Eye examination includes assessment of shape, placement, movement, and the critical red reflex test to rule out cataracts, retinoblastoma, and other abnormalities. For ears, evaluate placement. Normal is 30% of pinna above an imaginary line between inner canthus and occiput. Rotation, normally less than 30 degrees, and shape. Low-set ears often associate with chromosomal abnormalities. Universal hearing screening is recommended for all newborns before discharge. Document any pits, tags, or preauricular sinuses, which may be isolated findings or associated with syndromes. When assessing mouth, nose, and throat, remember that newborns are obligate nose breathers until about 6 to 12 weeks of age. Check palate integrity both visually and by palpation to identify clefts. Epstein pearls are benign white cysts on the hard palate that resolve spontaneously. Assess normal reflexes including suck, rooting, and gag. These have specific timelines for appearance based on gestational age. Examine tongue size and movement, noting abnormalities like macroglossia, enlarged tongue seen in Beckwith-Wheaton syndrome, or ankyloglossia, tongue tie. Document any cleft lip/palate or micrognathia, small jaw, which can impact feeding and airway maintenance. Congenital torticollis, or wry neck, results from spasmodic unilateral contraction of neck muscles, typically involving the sternocleidomastoid. It's caused by birth trauma, intrauterine malposition, muscle fibrosis, or venous abnormalities. While not immediately apparent at birth, you may initially detect a hematoma, or soft tissue swelling over the involved muscle. The characteristic firm, fibrous mass appears around 2 weeks of age. It's 1 to 2 centimeters in diameter, hard, immobile, and located in the mid-portion of the sternocleidomastoid. Clinically, the infant presents with the head tilted laterally toward the involved side, and the chin rotated away from the affected shoulder. Infants with torticollis require evaluation for associated conditions, including metatarsus adductus, hip dysplasia, and cervical spine anomalies. When the mass is detected early, most cases can be successfully treated with stretching exercises performed by parents. However, if the condition goes unnoticed or untreated, serious complications develop. These include plagiocephaly with asymmetry of facial and skull development, occipital flattening on the side opposite the lesion, and frontal bone flattening on the affected side. The key to preventing these significant cosmetic and functional complications is early recognition and prompt initiation of conservative treatment with stretching exercises. Chest and lungs assessment involves evaluating chest shape and movement. Noting barrel chest suggests air trapping, or pectus excavatum. Observe breathing pattern. Regular versus periodic breathing. Normal pauses under 20 seconds. Check for symmetry of breath sounds. Asymmetry suggests pneumothorax or other pathology. Assess work of breathing, looking for retractions, nasal flaring, or grunting, which indicate respiratory distress. Differentiate normal breath sounds from abnormal findings like crackles, wheezes, or stridor. Remember that occasional wet sounds immediately after birth are normal as fluid clears from the lungs, but persistent abnormal sounds warrant investigation. Cardiovascular assessment is heavily tested on the exam. Evaluate heart rate, rhythm, and sounds, noting normal first and second heart sounds and any abnormal splitting or extra sounds. Understand murmur characteristics, timing, systolic, diastolic, continuous, location, and intensity, using the grade 1 to 4 scale, where grade 1 is barely audible and grade 6 is audible with stethoscope off the chest. Assess peripheral pulses for rate, rhythm, and strength. 0 to 4+, where 0 is not palpable and 4+ is bounding. Always compare femoral pulses to brachial pulses. Femoral pulses that are weaker than brachial suggest coarctation of the aorta. Remember that universal cardiac screening using pre- and post-ductal oxygen saturation is recommended for all newborns. For abdominal assessment, first note the appearance. Normally soft, rounded, with movement synchronous with breathing. Examine the umbilical cord, counting vessels. Normally one vein and 2 arteries. Noting appearance and checking for abnormalities like omphalitis or umbilical granuloma. The liver edge is normally palpable 1 to 2 centimeters below the right costal margin in newborns. Bowel sounds should be present within hours of birth. Remember that most abdominal masses in neonates originate from the urinary tract. A palpable kidney or bladder is the most common cause. A scaphoid, sunken abdomen, may indicate diaphragmatic hernia, while marked distension suggests obstruction. Genitourinary assessment differs by sex. In males, check urethral placement, noting hypospadias if displaced ventrally. Ensure testes are descended into the scrotum and document first void. In females, examine labia appearance. Size relates to gestational age. Note any discharge. White discharge is normal due to maternal hormones, and verify vaginal opening. Ambiguous genitalia requires prompt evaluation by an interdisciplinary team. Watch for abnormalities like hypospadias, abnormal urethral opening, cryptorchidism, undescended testes, and hydrocele, fluid collection around testes that transilluminates. The timing and appearance of the first void are important indicators of urinary tract function. When examining the spine, check that it's midline and straight, with no skin disruptions, like dimples, hair tufts, or masses that might indicate underlying neural tube defects. For extremities, assess symmetry, movement, and digit number in both upper and lower limbs. Perform hip assessment to rule out developmental dysplasia using Barlow and Ortolani maneuvers. Distinguish normal positional deformities, like metatarsus adductus from intrauterine positioning, from structural abnormalities requiring intervention. Also document any birth trauma, such as fractures or nerve injuries, particularly brachial plexus injuries that result in asymmetric movement or Moro reflex. Developmental dysplasia of the hip is a spectrum of conditions from subtle instability to complete dislocation, affecting 2.5 to 6.5 per 1,000 births. Key risk factors include breech presentation, responsible for 30 to 50% of cases, female gender and family history. Incidence varies dramatically by ethnicity, likely due to cultural practices like swaddling that keep hips in unfavorable positions. Clinical assessment focuses on 4 key findings: asymmetric skin folds, limb length discrepancy, and 2 critical maneuvers. Barlow tests if a stable hip can be dislocated, while Ortolani tests if a dislocated hip can be reduced. Ultrasound is the diagnostic gold standard in the first month, as X-rays are unreliable before femoral head ossification. Importantly, 60 to 80% of clinical findings resolve without intervention. Metatarsus adductus is the most common congenital foot deformity, involving medial deviation of the metatarsal bones. It results from intrauterine positioning, especially in conditions like multiple gestations or oligohydramnios that restrict fetal movement. The condition affects both genders equally and is bilateral in half of cases. Importantly, it's associated with hip dysplasia in 10 to 20% of patients, making hip screening essential. Clinical assessment must distinguish between 2 types: positional deformities with flexible, easily correctable forefoot, and structural deformities characterized by high arches, medial creases, and limited mobility. Clinical assessment focuses on determining flexibility. Can the forefoot be abducted past midline? Positional deformities show good mobility with neutral heel position, while structural deformities demonstrate limited abduction, high arches, and sometimes heel valgus. The overall prognosis is excellent, with 85% resolving spontaneously by age 3. Treatment is type-dependent. Positional deformities require only observation or home stretching exercises, while structural deformities need orthopedic referral for casting and manipulation. Surgery is reserved only for rigid cases that don't respond to conservative treatment. The key to successful management is accurate initial classification. Clubfoot is a complex congenital deformity where the foot turns inward and downward, readily apparent at birth. It's one of the most common orthopedic anomalies with significant ethnic variation, occurring in 1 per 1,000 Caucasian births, peaking at 6.8 per 1,000 in Polynesians, and lowest at 0.6 per 1,000 in Asians. Males are affected twice as often as females. While most cases are idiopathic, with no identifiable cause, it likely results from combined genetic and environmental factors. Family history is significant, with 3% risk for siblings and 20 to 30% risk for children of affected parents. Clubfoot presents with 3 characteristic components: forefoot adduction, where the foot points medially, seen in 95% of idiopathic cases, pronounced heel varus and equinus positioning, with downward pointing of the foot and toes. The condition can be unilateral, but is bilateral in about half of cases. Severity varies significantly from relatively flexible deformities correctable with exercises and serial casting to rigid cases requiring surgical intervention. The key to successful outcomes is early recognition and immediate orthopedic consultation. Treatment can often begin in the nursery, with the approach tailored to the severity and flexibility of the deformity. Genu recurvatum is a rare congenital anomaly occurring in 1 per 100,000 births, characterized by knee dislocation or hyperextension. The primary cause is frank breech positioning in utero, accounting for 41% of cases in otherwise normal newborns. Other causes include prenatal developmental defects, leg muscle or nerve disorders, and generalized joint laxity seen in floppy baby syndrome. Associated conditions include oligohydramnios, elastic tissue anomalies, and quadriceps fibrosis, with hamstring deficiency. The condition predominantly affects females and is typically bilateral. Treatment of genu recurvatum is severity dependent and must begin early to prevent further deformity and functional impairment. Mild cases respond to physical therapy, combined with progressive serial splinting to gradually reduce hyperextension. Moderate deformities require serial casting to maintain the knee inflection. Severe cases with actual knee dislocation necessitate surgical correction. Regardless of severity, immediate orthopedic consultation is essential for optimal outcomes. Neurological assessment evaluates multiple systems. Check muscle tone by assessing resting posture, passive resistance to movement, and active movement against gravity. Test primitive reflexes including Moro, startle, rooting, palmar grasp, and sucking. Their presence and strength vary by gestational age. Observe behavioral states from deep sleep to crying, noting ease of transitions between states. Evaluate autonomic stability through color, respiratory pattern, and visceral function. Look for signs of behavioral organization. Hand-to-mouth movements, attentive focus, versus disorganization. Finger splaying, gaze aversion, color changes. Remember that neurological findings must always be interpreted in the context of gestational age and overall clinical picture. The traction response, or pull-to-sit maneuver, tests postural tone by evaluating the neonate's ability to resist gravity. The technique involves grasping the infant's hands and slowly pulling from supine to sitting position while the baby is awake and alert. In normal-term neonates, you should observe shoulder and arm muscle contraction, followed by neck flexion. The head should leave the bed almost immediately, with only minimal leg, remain erect momentarily when sitting, then fall forward. Additionally, flexion occurs in the elbows, knees, and ankles. Remember that neck flexion is normally absent in preterm infants less than 33 weeks gestational age. More than minimal head leg during the traction response indicates postural hypotonia and warrants further evaluation. Since normal postural tone requires integrated function of the entire nervous system, hypotonia may result from central nervous system disturbances, peripheral nerve problems, or skeletal muscle disorders. Be aware that large subgaleal hemorrhages or extensive caput succedaneum can create mechanical interference, making it difficult to distinguish between mechanical and neurologic causes. In these cases, assess other reflexes, tone, and activity levels for reassurance. Any infant with abnormal findings should be retested prior to discharge to ensure accurate assessment. The doll's eye maneuver is a critical test of brainstem function, performed by gently rotating the neonate's head from side to side while observing eye movements. The normal response demonstrates intact brainstem pathways. When the head turns right, the eye should deviate left, and vice versa. This opposite movement indicates proper function of the vestibulo-ocular reflex. Abnormal responses are highly significant. If the eyes remain fixed in position regardless of head rotation, brainstem dysfunction is likely present. If the eyes move in the same direction as the head rotation, this suggests either brainstem or oculomotor nerve dysfunction. When head rotation isn't possible, an alternative method involves introducing cold water into the ear canal to stimulate the semicircular canals. Normally, the eye should deviate toward the side of the cold water. Loss of this response indicates compromise of the pontine centers. This maneuver provides valuable information about the integrity of critical brainstem pathways in the neurologic assessment. The Gallazzi or Alice sign is a simple but important test for detecting femoral length discrepancy that may indicate developmental dysplasia of the hip. The technique involves placing the infant supine, with feet flat on the bed, aligning the femurs, and flexing both knees while ensuring the big toe tips remain in the same horizontal plane. Position yourself facing the infant's feet and observe the height of both knees. In a normal infant, both knees should be at equal height. A positive Gallazzi sign occurs when one knee appears higher than the other, indicating potential femoral length discrepancy. Any discrepancy in knee height should prompt immediate investigation for DDH, as this finding may be an early indicator of hip dysplasia. Proper documentation is essential, both clinically and for the exam. Include complete and accurate history documentation, including maternal, pregnancy, and delivery information. Document your systematic head-to-toe assessment findings, clearly distinguishing normal from abnormal observations. Include comprehensive growth parameters with appropriate plotting on growth curves. Always document your plan for abnormal findings and necessary follow-up. Remember that documentation serves multiple purposes: clinical care, legal protection, and communication with other providers. These documentation elements are particularly high yield for the exam. Always document gestational age assessment results with specific physical and neurological criteria used. Include all growth parameters with appropriate classification. Document vital signs and stability over time, not just single readings. For abnormal findings, provide specific descriptions rather than vague terms. 2.5 centimeter cephalohematoma over right parietal bone is much better than bump on head. Include risk assessments based on your findings, such as hypoglycemia risk in an SGA infant or infection risk with prolonged rupture of membranes. Some concepts appear repeatedly on the exam. Normal weight loss in term newborns is 5 to 10% of birth weight, with birth weight typically regained by 7 to 10 days of life. The liver edge can normally be palpated up to 2.5 centimeters below the right costal margin, without indicating hepatomegaly. Acrocyanosis is normal in the first 48 hours, but abnormal beyond that time frame. Meconium passage normally occurs within the first 48 hours of life, with delayed passage suggesting obstruction. These specific values and timelines frequently appear in clinical scenario questions, so commit them to memory. Certain high-risk findings require immediate recognition and action. Signs of respiratory distress include tachypnea, retractions, nasal flaring, and grunting. Abnormal cardiac findings include murmurs beyond 48 hours of life, absent or diminished femoral pulses, and cyanosis. Central cyanosis or persistent acrocyanosis beyond 48 hours always warrants investigation. Abnormal tone or reflex responses may indicate neurological issues, maternal medication effects, or metabolic disturbances. Concerning dysmorphic features may suggest chromosomal abnormalities requiring genetic evaluation. The exam frequently tests your ability to recognize these high-risk findings and determine appropriate next steps. To wrap up, remember that a systematic approach to neonatal physical examination is absolutely essential. Also, always make sure the infant is kept warm, as it can become cold during examination. Your assessment must integrate history, gestational age, and physical exam findings to create a complete clinical picture. The ability to differentiate normal from abnormal findings is perhaps the most critical skill, and this requires knowing age-appropriate norms. Remember that timing affects accuracy, particularly for neurological and behavioral assessments. Despite all our technological advances, the physical exam remains the cornerstone of neonatal care, and mastering it is key to both clinical practice and success on the certification exam. A neonate at 10 hours of life has scattered white papules on an erythematous base distributed over the trunk, back, and extremities. The most appropriate clinical assessment would be erythema toxicum neonatorum, miliaria crystallina, staphylococcal scalded skin syndrome. The correct choice is erythema toxicum neonatorum. This question is testing your knowledge of common skin findings in the newborn and the ability to distinguish between normal variants and pathological conditions. Erythema toxicum neonatorum is correct because it presents as white or yellow papules and vesicles on erythematous bases, typically appearing in the first 24 to 72 hours of life, and commonly distributed on the trunk, extremities, and face. It's a benign, self-limiting condition requiring no treatment. Miliaria crystallina is incorrect because it presents as tiny clear vesicles without surrounding erythema, typically in skin folds or areas covered by clothing, and is caused by sweat duct obstruction. Staphylococcal scalded skin syndrome is incorrect because it presents with widespread erythema, tenderness, and superficial desquamation, resembling a scald, and is a serious systemic infection requiring immediate treatment. A gestational age assessment of a neonate reveals popliteal angle of 90 degrees, square window wrist angle of 45 degrees, and minimal arm recoil. Based on these neuromuscular findings, the most likely gestational age is 38 to 40 weeks, 30 to 32 weeks, 34-36 weeks. The correct choice is 30 to 32 weeks. This question is testing your knowledge of neuromuscular criteria used in gestational age assessment and the ability to interpret specific findings to determine gestational age. 30 to 32 weeks is correct because these neuromuscular findings, wide popliteal angle, large square window angle, minimal arm recoil, indicate neuromuscular immaturity, consistent with a preterm infant in this range. With increasing gestational age, the popliteal angle decreases, the square window angle decreases, and arm recoil increases. 38 to 40 weeks is incorrect because a term infant would demonstrate much more neuromuscular maturity, with a popliteal angle closer to 90 degrees, square window angle less than 0 degrees, and prompt arm recoil. 34 to 36 weeks is incorrect because although closer, a late preterm infant would still show more neuromuscular development than described in the scenario. During physical examination, a 2-day-old term neonate demonstrates extension of arms and legs with abduction, followed by flexion and adduction when startled by a loud noise. This reflex is Gallant reflex, Moro reflex, tonic neck reflex. The correct choice is Moro reflex. This question is testing your knowledge of neonatal reflexes, their normal presentation, and how to distinguish between different reflexes. Moro reflex is correct because it's elicited by a startling stimulus, like a loud noise, and presents exactly as described: extension and abduction of extremities followed by flexion and adduction, often with crying. It's present at birth in term infants and persists until 4 to 6 months of age. Gallant reflex is incorrect because it involves stroking along one side of the spine while the infant is prone, causing the pelvis to turn toward the stimulated side. Tonic neck reflex, also called fencing position, is incorrect because it occurs when the infant's head is turned to one side, resulting in extension of extremities on the facial side and flexion on the occipital side, with no startling stimulus involved. During a painful procedure, a term neonate exhibits brow bulge, eye squeeze, nasolabial furrow, and open mouth. Based on these facial expressions, the nurse practitioner would most accurately document behavioral state change, feeding readiness cues, pain response. The correct choice is pain response. This question is testing your knowledge of pain assessment in neonates, specifically the facial indicators that are considered reliable signs of pain. Pain response is correct because the facial indicators described, brow bulge, eye squeeze, nasolabial furrow, and open mouth, are classic components of validated neonatal pain scales like the Premature Infant Pain Profile and Neonatal Facial Coding System. These facial expressions are considered among the most reliable indicators of pain in nonverbal patients. Behavioral state change is incorrect because, while pain can cause behavioral state changes, the question specifically describes facial expressions that are validated pain indicators, not general state changes. Feeding readiness cues is incorrect because feeding cues include rooting, hand-to-mouth movements, and sucking motions, not the distress facial expressions described. A preterm infant at 31 weeks gestational age displays gaze aversion, finger splaying, and hiccuping during a care procedure. The most appropriate nursing interpretation of these behaviors is signs of approaching extubation readiness, signs of disorganized stress, signs of organized self-regulation. The correct choice is signs of disorganized stress. This question is testing your knowledge of developmental care concepts, specifically the ability to recognize stress cues in preterm infants. Signs of disorganized stress is correct because gaze aversion, finger splaying, and hiccuping are all recognized autonomic and motor stress signals that indicate the infant is experiencing overstimulation or discomfort. These signals indicate the need to modify care to reduce environmental stimuli and provide supportive measures. Signs of approaching extubation readiness is incorrect because extubation readiness would be indicated by respiratory parameters and stability, not by stress behaviors. Signs of organized self-regulation is incorrect because self-regulation behaviors include hand-to-mouth movements, tucking, grasping, and sucking, all of which show the infant's ability to calm themselves, whereas the behaviors described indicate stress and inability to maintain physiologic and behavioral organization,